Hello and welcome to Conversations with Esther tonight. I believe you can hear me. Karibu sana daktari. Jacinta, kindly, if I see someone interfering there. Jacinta Moturi. I don't know how we get to manage this. Jacinta, now I think you've taken over the screen. I'm not able to do much. Jacinta Moturi. Thank you. Kindly, let's allow just daktari and I to control the session. So I will pray. Father, in Jesus' name, we thank you for being with us. Thank you, Lord, for watching over us throughout the week. And we pray that as we begin this session, Lord, you will lead us and instruct us. Have your way in Jesus' name. Amen. Amen. Let me share this so that we can start off. Just allow me, I think today we just, I'll have my, Daktari will have his camera on. The camera will be off. So you can see our screen. I just want to introduce Conversations with Esther for those that are joining us for the very first time. Conversations with Esther is an impact-driven professional platform. We offer consultancy and training. We are dedicated to transforming workplaces and individuals through meaningful conversations and practical solutions in mental health, human resources, legal compliance, and employee well-being. We empower organizations and professionals to embrace ethical and authentic leadership while fostering healthy workplace cultures built on respect, accountability, and excellence through our tailored corporate training programs, motivational speaking engagements, end-to-end human resource consultancy services, legal awareness initiatives, and career mentorship programs. We equip individuals and organizations with the knowledge, skills, and strategies needed to thrive in today's dynamic work environment. Now, at Conversations with Esther, we believe that sustainable organizational success is achieved when people are supported holistically and leaders act intentionally. Guided by our core values, integrity, excellence, and impact, we are committed to driving positive change, strengthening professional relationships, and promoting best practice across industries. Our vision is to create workplaces transformed by professional conversations like what we have today, respectful relationships, and intentional leadership. Our services include corporate training and capacity building, human resource consultancy, employee well-being and mental health programs, legal awareness, workplace compliance training, motivational speaking and leadership development, career coaching and mentorship programs. Now at Conversations with Esther Limited, we inspire conversations that transform people, workplaces, and organizations for lasting impact. To today's session, I know we've done our session one. We did week one on the 5th of August, where Daktari handled the symptoms and diagnosis of endometriosis. We had session 2 on the 12th of August, causes and theories around endometriosis. And today we are going to do session 3, management and treatment of endometriosis. Now, next week, 2nd of September, we will handle fertility and impact. of endometriosis, that is fertility, relationships, and the long-term impact on quality of life. What are the available treatment options for endometriosis? How can symptoms and pain be managed effectively? And what does long-term care look like? Allow me to introduce Daktari. I know he is well known, but it is good to give respect and honor where honor is due. Dr. Joseph Njagi is a consultant gynecologist and laparoscopic surgeon with special interest in endometriosis management and research. He is currently the Secretary General, Kenyan Society of Endoscopic Specialties, as founder of Laparoscopy Mashinani. Dr. Njagi and team have assisted various women in the rural and underprivileged areas using minimal access surgery. Now, Daktari is popularly known as the Kristo wa Neema doctor, and as always, I will ask him to sing that before he begins. And thank you, Daktari, for this sacrifice. I am aware you're out of the country. Thank you for settling down that fast to be able to join us. Karibu sana Daktari, the stage is yours. Thank you.
Yeah, thank you so much, Esther. Good evening, everybody. It's a really great pleasure to meet you again. And it's really great that we get to have this conversation, which, in my opinion, I think just really amazing. So first of all, I apologize because I know last week I was not able to make it. I think my schedule is a little bit busy and was not able to make it. However, I think it's good that we are here, and I think today's topic is the one that I think it's important as compared to the very first one that we've had, given the fact that we need to really know how do we manage these conditions. How are we going to take care of patients who we suspect they have endometriosis, or we have found that they have endometriosis? Because the treatment, basically, it's not that you're treating the disease, but treating the presentation the patient presents with. So having said that, I've been asked to do Kristo wa Neema yote, and we'll do that. Then I'll share my slides, and I hope you all get blessed. So it goes, Kristo wa Neema yote imisha moyo wangu, mifulizo ya baraka inamsha shangwe kuu. Unifunze nikupende, nikuandame kote, moyo wangu ukajae furaha na tumaini. Namshukuru sana Bwana aniwezesha huku na salama, aniongoza hata kule nyumbani. Yesu alinitafuta njiani mbali kwake, akatoa damu yake nipone hatarini. Kweli mimi mwiwa mkubwa wa neema daima, wema wako unifunge zaidi kwako Bwana. ili nisivutwe tena kukuacha emponya, nitwalie moyo wangu uwe wako kamili. Thank you so much, and I really hope you have been blessed. All right, so we have 1 hour, and let me see how I can quickly run through this. Let me see if I can share my slides here. All right. Okay, so today we'll be discussing about management of endometriosis. But before we do the management of endometriosis, we will just get a quick overview. And this is things that we possibly have talked about in the past conversations. This is going to help us at least know where we are coming from and where we are going, why this is important. Just a little bit of a background and a summary for those who could have missed our previous presentation. We know that the preference of endometriosis globally is quite massive. We're talking about 200 million women are suffering from endometriosis. So this is massive. I also want to mention that with this 190, 200 million women, Africa has not been accounted for, which is pretty sad. I give statistic whereby Kenya alone, if we would extrapolate this data, talking about 1 out of 10 women suffering from endometriosis, we would have about 1.5 million women suffering from endometriosis. So this is a condition that makes it important for us to have conversation. However, there's still very little conversation that is happening. We know we had a period, for those who are from Kenya, we had a period whereby now we are having conversations on endometriosis. We know there are lots of conversation going on social media. We have prominent people that we know who are coming out now vocal about it. We have media personalities who are coming out and talking about it. And the question that we are getting to get now is, why is it that we are having preference of endometriosis quite high at this point in time? And I don't think that prevalence of endometriosis has changed. One, we don't have data for women from Africa, Kenya, so to speak. However, I think there are a few things that we have improved over the last few, years, and is that now we are having open conversation and conversation like this, where we come together, we are having this intentional conversation, and we're actually speaking facts, because there's a lot of myth surrounding endometriosis, and there's a lot of gaslighting and shame around endometriosis that really makes us not have open conversation. The other thing that I feel it's rather unfortunate, and this is mostly for us who are in the science fraternity, is we've not done our research. So we really have no numbers to speak about. So we have to keep borrowing these numbers. So if you look at those numbers, therefore, you would actually say the continent of Africa has been very, very underrepresented on these numbers. We know that diagnosis of endometriosis can take anywhere from 6-7 years to 10 years. So there's a huge delay. And one can make a conclusion: the longer it takes to make diagnosis, the late the diagnosis, and the difficulty in terms of treatment. So patients get to suffer for a very long period of time without really having actual diagnosis. So it's really taking a long time to make the diagnosis. And we are only going to pick this diagnosis for women who actually are looking for treatment for issues like fertility. That's when we get to pick them up. What is very fascinating is that we have up to about 50% of women who suffer from infertility are likely to have endometriosis. And data is really showing us this, because we know that endometriosis directly affects fertility, whether it is through affecting the ovarian reserve from the ovary, where ovaries are getting affected and the ability to get pregnant significantly reduces, or to a point whereby there's going to be inflammation and attachment to the fallopian tubes, which are responsible for picking up uh, eggs and being able to facilitate the movement of the eggs for fertilization. That also is contributing to infertility. The cost of management endometriosis is quite expensive, and we only don't want to look at the money that is going into healthcare system alone. We're also looking at the time lost from work by these patients, the cost of having to make from one appointment to the other. They're not able to go to work. So if you look at lost wages and put all it together, the cost is more than twice the amount of treating endometriosis. So it's important for us to have this conversation early and to know appropriate treatment, if at all there is anything like appropriate treatment for endometriosis. But of importance is to be able to pick these this condition early enough where we are not getting it later with complication. So when we talk about some of the problems in terms of making decisions on treatment, we have three main principles of why we need to treat endometriosis. Endometriosis is going to present in two ways mostly. One is going to be pain. So the quality of life gets significantly affected. We know the pain is going to include pain during menses, which is dysmenorrhea, pain during sexual intercourse, dyspareunia, pain while passing stool, which is dyschezia, and this chronic pelvic pain. So about 80% of women who have endometriosis are likely to present with pain, and their quality of life is affected. They cannot go to work. They cannot function to their optimum during this period when they're having this pain. So that calls for need for treatment. The second thing that we need to call for treatment is infertility. As we've seen, up to 50% of women with endometriosis, whether they have or they do not have symptoms, they could present with fertility issues. And this needs to be addressed. And there's a really big conversation about fertility. So let me not just pass through it without acknowledging that it's a very, very big conversation, whether the patient is going to have natural conception, whether the conception is going to be through IVF, which is assisted reproductive treatment, whether the infertility is going to be with the patient eggs, is this going to be ovum donor? What is the cause of infertility? Is it that we have occlusion of the fallopian tube with preservation of ovarian reserve, or is it ovarian reserve that has declined to a point whereby they cannot facilitate natural conception equally? They cannot have enough eggs to have an IVF from their own eggs. So this becomes a big conversation that one needs to have. We also have patients who have endometriosis, but they don't have symptoms at all. So these are going to be incidental finding. You're doing an ultrasound scan for let's say a patient who has, let's say, fibroid or whatever, or they've come in for a routine check, only to find that they have extensive disease and they are symptomatic. So the question becomes, how are you going to manage this patient? Are they going to manage the same way? The answer is absolutely not. The patient who presents with pain but no desire for fertility will be managed differently from patients who present with pain and fertility desire. It can be a patient who presents with pain but has completed family size. So that means they don't want to have more children. The treatment is going to be different. So when we talk about management of endometriosis, it's not one size fits all. You need to customize a treatment to fit the patient's needs and their desire. So the shared decision-making factor has to be, the treatment has to be patient-centered. What I mean by that is that you're not treating the disease, you're treating the patient. And the patient has what they want, what they like, what they wish, what their wishes are, what they don't want. That has to be put in consideration. And how that is going to be put in consideration is by giving them as much information as you can possibly do, unbiased information, that it can help them to make informed decision for their treatment. That becomes very important in the management of endometriosis. Again, speaking on that, we also need to consider what are the side effects. And when I talk about medication, those that I'm going to be emphasizing on their side effects. What are the side effects of the treatment that you are giving patient? Some medication patient can be able to tolerate, others patient are not able to tolerate. So you will also need to find what is the profile of the side effect and what is the individual efficacy. What that means, it doesn't mean you're giving medication is going to respond to patient in different ways. The medication we give patient, they respond very well. Patient pain disappears. They are okay. Everything is fine. The same medication you're going to give exactly to a different patient with possibly the same severity of the disease, everything the same, but they don't respond. These symptoms don't get better. So this has to be thought through when you're deciding. Number three, you need to also look at the cost. Not everybody is going to afford this medication in the same way. For example, when we put patient on hormonal treatment, this medication can be expensive. So we usually get patients who come back to our clinic. They say pain is still there, it's not getting better. You're trying to find why you're able to take your medication as prescribed. And the patient will say, I bought medication for the first month, then following month, I was not able to get medication. So I could not proceed with the treatment. So it was very difficult. Some will come and say, it has taken me long to come back because I was trying to get money to afford your consultation fee. So this becomes a genuine challenge that you have to acknowledge. Are you then going to offer this patient the same options of treatment? How is patient going to be compliant to the treatment that you're giving them? It makes no sense if you give patient treatment and only to find that actually they're not responding to the treatment whatsoever. So we have to also put that into consideration. Access to expertise. Unfortunately, there are not quite many experts for endometriosis, and the reason being that for endometriosis, one has to be very, it's where you like a certain field and you commit yourself to certain fields. There is the same reason why people do subspecialization. Some are going to subspecialize with fertility. Others will subspecialize with mother and child when they are still pregnant. Others are going to specialize in cancers. So still, again, this depends on one's interest. So there's still limited specialization or specialized expertise in the management of this condition. So of course, someone who's seeing, let's say, 100 patients every 2 months for endometriosis, definitely they are going to be better expert than someone who's seeing, let's say, 10 patients every 2 months. So that also becomes something that is very important. What about availability of this medication? I think last month or the month before that, we had crisis whereby Dynogest was out of the country, and we were getting crisis patient calling and saying, prescribe this medication, I cannot find it in any pharmacy. And we had to, change options of treatment. So these are genuine challenges that you also have to put in consideration. What is going to be the consistency, availability of this medication? Are they going to be available where the patient is? Where is the patient coming from? If the patient is coming from a rural place, are they able to get these medications whereby they are not really fast going medication? Then the pharmacy is not stocking these medication. No conclusive evidence on medical therapy or surgery is generally superior for pain relief. So we still do not have consensus where we can say this is a magical drug for the management, and this still makes it a big, big problem for us to really say this is the best option. So again, when you put this slide is very important. And I say this is very important because this is what is going to help us to decide on the management and the follow-up of the patient. Once you leave any of these consideration, which is going to help you in decision making, then you're going to make wrong choices. So then you really find that you're going to have different opposing strategies. So one might work for the other. Let's say a patient wants fertility, you cannot put them on hormonal treatment. Maybe patient has fear for surgery, so then maybe option is is surgery. Then they have fear for surgery, or they cannot afford surgery. How are you going to manage these patients? Maybe they have been on medications, or you don't have, maybe they have been on pain medications and you cannot really put them on pain medication. How are you going to manage this patient? So that becomes very important factor for you to consider when you're deciding on the treatment. Now, 4 categories we say for the management of endometriosis. 1 is painkillers, 2 is hormonal treatment, surgery, and non-medical options. So these are the 4 categories of management. And as you can tell, there's not quite much options out there. So first, we look at the pain medications, which is analgesic. So pain medication, as I like to tell my patient, is that pain medications are just pain medication. So you're using this medication to reduce the pain. However, in most cases, you're not taking care of the root cause of the problem. So what does that therefore mean? It means that when the efficacy of the medication goes down, the pain is going to come back in most cases. However, the NSAID and the NSAID are medication like ibuprofen, diclofenac. These are important medication because they help with inflammation. And that's why they are called non-steroidal anti-inflammatory drugs. These usually are the first line. Now, what patients are going to really benefit? These are patients. Now, let me back up first. Before you consider, and I think I talked about this, there's the very first module that we spoke, you will need to perform imaging to be able to tell the severity of the disease. So as much as you're starting these patients on treatment, again, ask yourself, is this early disease, is this intermediate disease, or is this severe disease? Because the outcomes are going to be very different and the response are going to be very different. The reason is because if you have early or minimal disease, patients are likely to respond to this anti-inflammatory drugs. We also have to understand, how does a pain come about? The pain is basically the nerves which are sending signals to the brain to suggest that there is tissue damage, which is calling inflammation, which we know where this inflammation is coming from our very first series where we talked about endometriosis, is when you have the presence of tissue that are similar to the one that line inside the uterus, outside the uterus. So every time there's menses, there's going to be inflammation. Basically, inflammation means there's injury to that tissue. Now, because there are nerves there, which are pain nerves, which we call the nociceptors, they are going to send this message to the brain. And now really, this is very important for us to understand why some patients are going to have treatment, including surgery, and the pain is not going to go away, something we call central sensitization, which I'm going to talk about in a little while. So when we are giving this medication, all that we are doing, we are reducing the inflammation, and this helps with less stimulation of these nerves because the inflammation is reduced. That's why they are called non-steroidal anti-inflammatory medication. So once you give this, reduce on inflammation, the pain is going to be less. However, we've also seen other medication. You're going to leave Panadols, which are painkillers. And then there's this ladder, what we call pain analgesic ladder. So there's what we start first line going. Unfortunately, we are finding many patients now who are going on opioid medication like morphine, which I think we all of us know, medication like pethidine, medication like codeine. This medication now becomes the very top of the ladder. And one of the challenges that we are finding now with patients who are using the medication, they are developing dependency. I don't want to say addiction, because that does not really sound very favorable. These patients are developing dependency on this treatment, which now becomes very, very, very difficult for you to manage this patient, because not only are you dealing with the disease, but we also dealing with a patient who has dependency. So when we are talking about pain medication, we have to be very, very, very careful. Now, as you can see on that line is saying, pain medication have limited evidence quality. So there's really not much evidence that is going to help with endometriosis. So if you've been taking pain medication, let's say for 2 months, 3 months, a year, and the pain is not going away, it's not a brainer. that this medication is only pain medication and it's not going to help because the disease is still there. Unfortunately, in this time that you are using to take this medication without provisional diagnosis, what you're dealing with, this is also contributing to the first slide. Remember what I said, it takes about 7 to 10 years to make diagnosis of endometriosis. So these are some of the factors that are going to contribute to delayed diagnosis because patients are used to going to over the counter and then you're getting this medication. And then I also say that some pharmacies are not helpful at all in most cases. You go, they never tell you. There's one patient who came to me, they say, I have my favorite pharmacist who he knows me. When he sees me, he knows, oh, she's come for that morphine. And then he gives me morphine, my life is good. And this is what I told the patient, that is your worst enemy. That is one of your worst enemy because he knows that you come, he's going to give you this medication, and he knows very well you are forming dependency to that medication, and that pain medication is not going to help. So this is the thing. If you're using pain medication for a duration of, let's say more than a year, pain is not getting better, then you're on the wrong line. The next option is hormonotherapy. We have first, second line of hormonotherapy, and I think there's a slide on hormonotherapy, which I'm really going to talk about it. Then we have the surgery. The surgery, we feel, is two options. We can have conservative surgery, and we can have pelvic clearance. Conservative surgery is where we are conserving fertility. I need to mention this clearly because most patients are offered solution of a hysterectomy as treatment for endometriosis, which I think is not correct. Hysterectomy does not manage endometriosis whatsoever. And this is exactly where I was saying earlier. The treatment should be determined by the patient desire. Do not offer patients treatment, which is a hysterectomy, if they are still not ready to have a hysterectomy. So patients need to be educated. Patients need to be told the options. And they need to decide what exactly do they want to do with their body. Remember, you're still the one who gets to make the decision and the choices for your body and for your treatment. So that becomes very important for you to decide. So conservative, you're going to have excision and there's also ablation. Now, there's a lot of conversation that is going between excision of the endometriosis and ablation. Basically, ablation means you're burning the disease. Excision means you're cutting out the disease, which is a gold standard in terms of surgical treatment. However, you could have very minimal disease, very little tiny lesions, which are causing patients excruciating pain, which do not need to be removed. So there's still role of ablation in terms of management of endometriosis. So if you're told that you had ablation, just don't fuss about it. The question is, how much disease was there to be burned? If you're having extensive disease, which is moderate to severe disease, ablation has zero role, and patients should be offered in terms of surgery, excision surgery. So if patients want to preserve the uterus for whatever reason, whether it's fertility or they just do not want to have the uterus removed and they do not have adenomyosis, that option should be given to them. However, for us who are in healthcare, we are very quick to remove women's uterus for a reason I still do not understand, that where you're having pain and the pain is not getting better, is not responding to the medical treatment, then you're offered the option of a hysterectomy, which I think that should be the last option. And this should be offered for patients whereby endometriosis has been ruled out and what you actually think is still causing the pain is adenomyosis. You have talked to the patient, they have no fertility desire, you've tried all possible hormonal treatment and it's not working, the patient is not getting relief. Then in that case, you can say, okay, fine, we've tried. Do you want to have fertility? No, everything is fine. Would you consider hysterectomy or removal of the uterus as one of the options of treatment? Only in those circumstances, in terms of surgery, that should be offered. What about non-medical? This is what we call the adjunct treatment. This is going to include physiotherapy, is going to include these adjunct Chinese medication, acupuncture, dieting, and so on. However, we really don't have much data that is talking about the efficacy of these non-medical option of treatment, but it really helps. Now, as much as I'm talking about the medical, about the treatment and the category of treatment of endometriosis, remember one thing that I mentioned is very important. You need to have had good imaging or diagnostic of endometriosis where ultrasound scan has been performed by an expert We know exactly where we are in that spectrum of disease. Are we dealing with deep endometriosis? And I hope some of us can remember what we talked about, deep endometriosis, what it is, and where exactly are we? And second thing, what is the patient desire, as we have actually talked about. Now, we need to mention this. As much as I've given category 1, category 2, category 3, category 4, it does not mean this is going to be the process of treatment that you start patient with analgesic. If it doesn't work, go to hormonotherapy. If it doesn't work, you go to surgery. If it doesn't work, you go to non-medical option. This can be substituted at any point. Surgery can be the first option that you're giving the patient. Non-medical can be the option that you're giving the patient. Hormonal treatment can come after surgery. Analgesic can come after surgery. So this is not a progressive, stepwise escalation of treatment for patients who have endometriosis. So we talked about analgesic, which are pain medication. I've really talked about pain medication, and I've said we have the non-steroidal anti-inflammatory drugs, which may be offered with combination of other treatments. So NSAID or pain medication can be offered with surgery. Pain medication can be offered with hormonal treatment. There's really no one way. However, we need to mention that there's a weak recommendation based on very low quality of evidence. There's really no much evidence that is showing this pain medication are going to help in any way in terms of reducing progression of endometriosis or long-term effect of management of endometriosis. So pain medication is pain medication. And for me, when patients come to my office, I really do not discuss about pain medication because it's pain medication. I'm going to discuss all other options. Because again, as I said, it's not a brainer that you know that you're taking pain medication. When these pain medications are not working or the efficacy has gone down, the pain is going to come back. We know that these NSAID, they lead to gastrointestinal side effects. So patients are going to present with epigastric pain or gastritis because we know that's one of the side effects from these medications. So you also need to ask yourself, how long am I going to give this patient this medication without really having to suffer the side effects of this medication? And are you going to add some medication to also counteract the side effects of this medication? But then if you're adding a medication, how long are you planning to put these patients on this medication? We know that also that the NSAID can also interfere with the fertility, which is again can reduce the ovulation or inhibit ovulation. So if a patient has fertility desire, what conversation are you going to have with them? Are you going to offer them these NSAID? Are you going to offer them options of hormonal treatment where we know hormonal treatment is not going to support ovulation or fertility during that time? So then this conversation comes in and you say, patient, what is your immediate need or desire? Is it to get pregnant? Then you know you will need to use less of hormonal treatment or actually no hormonal treatment. And again, now you're seeing you're less likely going to use the NSAID. So that means if a patient has pain and they have fertility desire, then surgery becomes the possible option of treatment. Now you can start seeing how we are able to really put the patient at the center of the decision making, and is going to help us decide to give the patient the very best. So the patient has to be at the center of decision making, and their needs and desires should be put at the center of the decision making. So we also have the, neuromodulator. These are antidepressant, and most patients are going to be given antidepressant for whatever reason, because they are thought they are, depression. But we know that there's no clear superiority over placebo for chronic pelvic pain and carry those limiting side effects. So these are going to be side effects, and there's really no much effect on these medical treatment. Now, what about hormonal treatment? So hormonal treatment is going to include our traditional combined oral contraceptives or combined hormonal contraceptives. So when you're talking about hormonal treatment, basically we are talking of whatever medication is going to either mimic a hormone or is going to directly affect production of hormones. And they are different. So for example, our oral combined pills, that is going to include progesterone and estrogen. What are they going to function? How are they going to use? Why are we using them? You really need to understand what is being aimed when we are giving this medication. Now, there's strong recommendation for patients who have pain during sexual intercourse, pain during menses, and when they have non-menstrual pelvic pain, so pain which is not related to their menses. So these are patients number one. You need to also have performed imaging ultrasound scan done by an expert, and we are finding in this spectrum of disease, where exactly are they? That becomes very important for us to remember. So available as oral pills, we know they can be vaginal ring, they can be transdermal patch. No route is preferred based on current contraceptive evidence. So it's basically what is going to work for the patient. There are patients who do not want to use medication that have estrogen because of the side effects of estrogen, weight gain, if they are hypertensive, if they have side effects. There are those who are going to take progesterone. You know the side effects of this medication. How are you giving this medication? Is it going to be the cyclic options where you give every month and then they're still getting their menses? Is it going to be continuous dosing whereby there's no break in between? So that means you're pushing away their menses. That way, they're not getting their menses, they're not getting pain during their menses. So what is the indication of your treatment, and what are you aiming to accomplish? For how long are you going to give this patient? What are side effects of this medication? And we're going to see different options of treatment in terms of hormonal treatment and some of the side effects. So we're going to see what is, are they have coagulation risk, that is forming clots, which we know that then estrogen is going to predispose them to some of these complications, metabolic, bone density, whereby we are stopping the hormones from the brain, the follicle stimulating hormone, or what we call the GnRH, which stimulates the part of the brain to produce other hormones which are going to trigger the ovary to produce hormones. So you need to discuss some of the side effects. Some of the side effects include breakthrough bleeding or spotting. So once you put patient on some of these hormonal treatment, what are some of the side effects? Patient need to understand. You don't want patient to be coming back to you and they say, I've been spotting, I've been putting a panty liner for the last 1 month since I started this medication. Is not very okay for me. Well, they needed to know that is one of the side effects of giving them some of these progesterone-based medication. So now you really see how you need to prepare the patient. They need to have this conversation. They need to understand what is the treatment going to be like. Now we start with medication that we call GnRH medication. So now the GnR medication, for some of you, is a medication that we are going to tell you that this medication is going to put you on medical menopause. What it really means, we are cutting off your hormone production from the part of your brain. So GnRH is gonadotropin releasing hormone, which is going to produce this GnRH hormone, which is going to stimulate part of your brain called the pituitary, and then the pituitary is going to produce a hormone called follicle stimulating hormone, luteinizing hormone. Luteinizing hormone is going to be responsible for ovulation. Follicle stimulating hormone is going to be responsible for stimulating the ovary to produce estrogen. So I think now you see that line. So once we block these hormones from the brain, then we are putting you on medical menopause. What does that therefore mean? It means the following, that you're not going to get your menses during that period you're on this treatment. That's number one. The second thing patient need to know and clearly have it very clear in your mind. What are possible side effects am I likely to get? Some of the side effects is a side effect that's similar to some woman who is on their menopause. It's going to be mood swing. It's going to be dry vagina. It's going to be night sweat. So all this needs to be actually discussed. The second and the most important thing is reduced bone density. So their bones can become weak. That therefore means you cannot give this medication for more than 6 months. Now we have two options. We have what we call GnRH agonist and GnRH antagonist. I am actually going to talk about it in the next slide. So the recommendation is for pain reduction, and there's really no much evidence. Again, you can really see possibly from all the options that I'm really talking about, there's really still not much evidence Again, this should be one of the last, in terms of hormonal treatment, coming almost the last options when we are giving medication. For patients that you are going to use for a very long time, more than 6 months that I've mentioned, you need to give what we call add-back therapy. That means you're supplementing them with estrogen. They need to know about the side effects I've talked about: dry vagina, hot flashes, headache, weight gain, decreased libido, reduced bone mineral density. Then a patient need to understand what part of my life is very important. There's somebody who just, I don't want my vagina dry. That to me is the most important part of my life. I need to enjoy sex. So then you actually need to talk to them and tell them this then might not be an option that is sufficient for you. Somebody might just have an issue that, the headache is really bad. Maybe I suffer from migraine. Then that helps you to know what options are you going to give them, what option are you not going to give them. Then you have a very special group there, adolescents. Adolescents you will only use after long specialist discussion, long-term bone health risk. Sorry about that. Where are we? All right, you guys will need to allow me to pick this because this is my wife who's calling. Hello? Silas, let me call you. Really sorry, guys. That is duty calls. Sorry about that. So then you need to have if they're adolescents, these are a very special group that you need to have a discussion with them. You need to really educate them. And again, as I mentioned, their treatment should be well planned and thought through. Next year, then you have so of course I've talked about the GnRH agonist, the GnRH antagonist. So again, this is a little bit complex, just different of this medication. Now, why this is important? Because these are the new molecules, and these are really not very much available, especially in Africa, because of course, their cost and everything. There's still a little bit of debate on their efficacy and the cost. And then you're going to find that there's still weak recommendation evidence on optimal doses, duration, and need for add-back therapy is still developed. So there's still a lot that we really don't know about this medication. So what we have been using are these GnRH agonists. Why this came up is because they are very quick to work. So I want you to think about it this way, as I was talking about the hormone. The GnRH agonists, they are going to stimulate certain hormones, which are going to increase very high. And then those are going to send a message to the brain that we have so much high of these hormones, let's say, for example, the estrogen. And once that gets stimulated, then the brain is going to shut down because there's already enough, because that's how really our body works. It's what we call the negative feedback. There's positive feedback. I don't know, some of us, we can remember a little bit of that. Biology is very important. Now, the antagonists, they actually themselves stop at the level of the brain or the GnRH. So they actually stop this. So you find that they work very quickly and they are more tolerable, and they are reversed, like, because these are oral tablets, their effect can be reversed very quickly. But as we talked about availability, cost implication, that has also to be considered. The other medication that some of us I think would have heard of, letrozole. Again, this is not very commonly used in terms of management of endometriosis because of their side effects of a stimulation of the ovary. So then these will have to be given in another option. So then their use becomes really limited. What about a medication called danazol? Some of you possibly would relate with some of these medications, and I think that's why I'm talking about most of these medications. Danazol is no longer used because danazol, what it does, it's meant to stop the estrogen, and it gives you the side effect of this medication, which is going to be elevated androgen. So when I talk about androgen, I mean the male hormone. So that means the side effects of this medication is going to include the patient is going to become hairy, The patient is going to have hoarse voice. The patient is going to have muscle cramps. The patient is going to have deepening of the voice. They're going to increase edema. So the side effects, the benefit of the medication and the side effect of this medication, the side effect outweighs the benefit of the medication. So it's usually reserved for only a situation whereby no other medical therapy is available. And we also need to find what is the evidence of their efficacy in terms of management of endometriosis. We find is very, very minimal. So there's still a very limited role of these medications in terms of management. And this is now why it should be very important when you're seeing your doctor who is managing you, you really need to ask them, depending on whatever treatment they are putting you on, what is the side effect of this medication? What are the alternatives? What am I looking at? What is it likely to do? What is the long-term effect of using this medication? So when do we get to give this medication? Assuming that surgery, and we actually say in management of endometriosis, the gold standard for management of endometriosis is going to be surgery, because surgery, we are going to remove the disease. But as you have seen, pain medication stops pain. The disease is still there. Hormonal treatment is only going to suppress the side effect. It's going to reduce the symptoms, which is going to be stopping the menses, pushing the menses, and stopping these hormones. But the disease is still there. So what that therefore means, the moment you stop using this medical treatment, it's very likely and almost always that the symptoms are going to come back. And that's the reason most patients are going to be offered the option of pregnancy. The symptoms are going to go away because the pregnancy is meant to work in the same manner as these medications are working. Because you stop menses, when a woman is not pregnant, she's not getting her menses. So she's going to get relief of symptoms as long as she's pregnant. But the moment she gets to deliver and the symptoms come back, and the menses come back, the symptoms are going to come back because this tissue gets stimulated in the same way the lining is being stimulated. So the symptoms are going to come back. So at least now you have an idea why most patients are going to be given pregnancy as an option of treatment, because for that 9 months and maybe 6 months of breastfeeding after delivering, they're going to have relief. So before surgery, we know that there's no evidence that this medical treatment or hormonal treatment are going to have any effect. And I say this because sometimes patients are told that you will give you this hormonal treatment as we prepare for surgery. So we know that there's strong recommendation that there's no controlled evidence of benefit of using this medication in preparation for surgery. So if you have decided that the treatment of the patient is going to be surgery, surgery and surgery alone. So there's no preparation whereby you're going to put these patients on hormonal treatment. They may still use as bridge for symptoms unless patient is waiting, they are not ready for surgery, or the waiting for surgery is long and you want to stop the symptoms, then they can be put on medical treatment temporarily. What about after surgery? Of course, after surgery, we have seen significant benefit of the hormonal treatment, which includes improved immediate pain outcome when immediate pregnancy is not desired. But if the patient has fertility desire, please do not put them on hormonal treatment. They should not be on hormonal treatment because that is only going to delay and prolong their pregnancy. And we also know that increases the risk of recurrence because we know that endometriosis can recur. Reduce the pain recurrence within 12 months and reduce the disease recurrence. So they actually slow down the risk of recurrence after surgery and should never be prescribed solely to raise future pregnancy rates. So when you're giving this hormonal treatment, it has no whatsoever any effect on improving on future fertility, which is something that should be considered and discussed very, very, very keenly. The third option, which is surgical, we said surgical option is one of the gold standard. We talked about ablation, we've talked about excision, whereby if you have deep endometriosis or you have extensive disease, then you need to offer a patient the option of excision. Now, how should this be done? The gold standard for the management of endometriosis is laparoscopy. So sometimes I usually tell patients that endometriosis specialist should be a laparoscopic surgeon. we find very low or limited role of open surgery for the management of endometriosis. Sometimes I say that and, it's used against me, but this is a reality because the laparoscopy is able to see better, is able to magnify, handling of the tissue is significantly better. So for any facility that is specialized in endometriosis, in most cases has to be very high skilled in laparoscopy. So it should be meant to reduce pain, which is a strong recommendation. There's really not much in terms of fertility, but surgery is mostly meant to improve on pain, whereby if the patient then has less pain, then they don't have to be on a hormonal treatment, then it's possibly going to give them a chance for fertility. It's going to be preferred over open surgery. We know why we say that laparoscopy is superior than open surgery. There's less pain, less hospitalization, quick recovery. There's less need for pain medication, and the patients get to have better outcomes in terms of cosmesis. And then it refers to a center of expertise where advanced laparoscopic skill is not available locally. And then the surgical risk, of course, the complications has to be decided because there's high risk of complication from surgery as compared to patients who are going to undergo medical treatment. So patient will come and ask, what are some of the risk factors of some of the complications of surgery? Of course, surgery, there's bleeding, there's injury to the tissue, there's anesthesia complication, we know. And the more the extensive the disease, the more likely to have severe risk of complication. So for example, if you're having a patient who have minimal disease, the risk of complication is significantly low as compared to someone who has disease on the bowel, disease on the diaphragm, disease on the lung, disease on the ureter. So the risk of complication is significantly high for patients who have advanced disease. Unfortunately, these are patients who medical treatment is really not an option for them. So you have no much option in terms of medical treatment. The option you possibly have is surgery, but then again, you find the risk of complication is significantly high. And the risk of recurrence for patients who have extensive disease is higher than patient who has minimal disease. So this is a very important conversation that you need to talk with the patient. You need to have them understand. Sometimes patients are going to come in my clinic and they're going to tell me, Dr. Njagi, you talked to me about it. I know this is a complex surgery. You're telling me the surgery is going to take me about 3-4 hours. Please guarantee to me that then this is the cure. Unfortunately, you have to tell them, unfortunately, I'm sorry, this is not cure. We're only managing which is there. And if you have advanced disease, then the risk of recurrence is still high. And sometimes patient might ask, then what is the reason for me having surgery if I'm going to have a risk of recurrence? And I say, well, it doesn't mean it's going to recur, but the risk of recurrence is very high. So the question is, would you want to live the way you are now? Or would you want to have a quality of life 1 or 2 years? And if the recurrence is going to come back, it doesn't mean that it's going to come back to this severity. It's possibly going to be now minimal disease. Or are you going to wait until we get to a point of whereby there's no point of return, when you have what I said, sensitization of the nerves, whereby even when you give surgery, the nerves have been sensitized to always interpret pain, whether there's stimulus or there's no stimulus. And that becomes now the most difficult patient for you to manage, because it doesn't matter what you do. It doesn't matter what you give them. It doesn't matter what surgery you do, whether you remove the uterus or whatever is offered to them, the pain will not disappear. So we need to have that conversation. Patient need to understand what you're dealing with. Patient need to understand how complex this is, and they need to make informed decision. So again, I talked about excision versus ablation. What does the technique means? I did mention that excision, you're cutting out the disease, and this is significantly going to reduce the pain. And you need to follow up this patient, because we know about 5 years, about 60-70%, they have a risk of recurrence. What about preferred for deep lesion? Deep lesion, if you have what we call deep endometriosis, there is no role of ablation, as cannot confirm the entire lesion has been destroyed. Is there a role for ablation? As I said, yes, there's a role for ablation. This is going to be minimal disease, and there's no significant difference between excision and and ablation. And again, we have also seen data is now showing that we have patients who are going to present with significant improves quality of life after this treatment. Weak recommendation favor excision where a choice exists, and by choice, whether it's medical treatment or it's ablation. Now we have other options for conditions like endometrioma. We see that endometrioma is when you have disease on the ovary, and there are different options. Now, there's a lot of conversation whether you're going to remove that cyst wall, which has disease. Are you going to burn it with energy or with laser? Or now we can actually even destroy that cyst using carbon dioxide or even alcohol. So there are different options out there. Now, why important about ovarian endometrioma is because you need to preserve fertility, because we know that the eggs are on this ovary, and once you're offering treatment, then you need to also ask, what is a patient point in terms of fertility? If their fertility is still very important, that has to be considered. So you're going to weigh between recurrence of the disease and destroying the ovary. In some of these patients, you have to tell them, you know what, we are not going to remove the cyst wall, which is the most effective option, but it's going to reduce your risk of fertility. We are going to burn, which means there's going to be a higher risk of recurrence, but at least we are going to preserve fertility. So now this conversation becomes very, very important. So you need to minimize ovarian damage, which has a reported risk of ovarian failure, bilateral endometrioma, which is removed, which goes to about 2.4%. You need to reduce the number of repeated surgery as much as possible. So if you think that you're going to need surgery, again, have this conversation with the patient. Tell them we are going to preserve fertility, but then you need to think about fertility because of risk of recurrence, and maybe the next time we need to operate, whether they are going to try fertility after surgery, or they are going to remove the eggs, which we call ovum pickup, and then freeze them, then that's an option that should be given to them. Are you going to do ovarian ovary pickup? No. Ovum pickup before surgery or after surgery becomes a conversation. What is the patient's fertility level during this conversation? Do they have good ovarian reserve? There's a test we call anti-Mullerian hormone, or we can do follicular count, follicle count, which can be done through ultrasound scan. What is it before you even start offering these options of treatment? That becomes a very important conversation that you need to offer them. Now we have the deep endometriosis. This is the one that I said you have more than 5 millimeters of infiltration of the disease. Now that has to be excised. Now, what does that there mean? It means that when you are managing deep infiltrative endometriosis, you might need more than you as the surgeon. So you might need a urologist if the disease is infiltrating the bladder or the ureter. You might need to have a colorectal surgeon if you have intestine that have been infiltrated. All this is very important for you to put in consideration. Now we know that for patients who have deep endometriosis, about 5 to 12% of the cases are going to have endometriosis. And we also know where most of this disease is going to be. Much of this disease is going to be on the sigmoid or rectum. So you need to prepare the patients and have them understand that depending on the severity of the disease, you might likely need to have that part of your intestine cut. What does that therefore mean? It means you have risk of complication. We can include the bowel leak. What does the bowel leak mean? The bowel leak means that you might need a stoma. A stoma is the diversion in case you get this complication. But then that is going to improve on your quality of life. But then even before you decide to cut this part of the intestine, does the patient have symptoms for the intestine? Do they have constipation? Do they have bloating? Do they have pain while passing stool? Do they have pain while having sexual intercourse? So that the treatment is not offered just because there's disease, but the treatment is offered because the patient has symptoms that suggest that they need to have treatment for. So that becomes a very important conversation you need to have before you determine the aggressiveness of the disease. Woo. Still have a few more slides to go, and I finish. So again, you see that the need for pain medication after surgery is going to be significantly low. This rate of complication has to be discussed. Again, you can see there's risk of recurrence. Recurrence is going to depend on the skill of the surgeon. Do you have the multidisciplinary team, or what was the extensive of the disease. Again, these are not very important, so I can start cruising through these. This is really interrupting the pelvic nerve. This was destroying the nerves in management. I think now we know that they really add no benefit of a conventional laparoscopy surgery alone, and they are not recommended now. This is whereby you destroy the uterine nerves, or the uterosacral nerve ablation, the laparoscopic uterosacral nerve ablation. You burn those nerves. Again, we know that does not have role. Or cutting out their presacral nerve. And this has been thought that it may benefit for selected patient with midline patient and after surgery, if they still don't have resolve of the symptoms. But then this is a very, very complex option that should not actually be offered unless every other alternative has been considered. Removal of the uterus, again, I'm not going to talk about, because I really did mention about removal of the uterus hysterectomy when I started my conversation. However, we know that does not guarantee cure. So the benefit as compared to what does a patient want in terms of fertility should be significantly considered before you offer patient hysterectomy. The only time you're going to offer patient hysterectomy if you know that they have adenomyosis, which we know adenomyosis is the presence of this tissue on the uterine wall, and there are no other options remaining. And this is a very conversation you need to have with the patient. So it's it does not offer any benefit unless patient really knows what it looks like. Again, remove all visible endometriosis lesion at the same time of the procedure. So if you have to remove the uterus, again, make sure you remove endometriosis. Disease can persist all near the retained cervix. I know some of you know that we had that legal case, and now that Esther is here and she's a lawyer, you know that legal case that we had, that the patient had their uterus, their cervix removed. And if you remember very well, it was endometriosis, adenomyosis. We went to the court, and the patient was offered 150 50 million shillings. Wow. That was quite something. Now, again, see this is what data is actually telling, that when you leave the cervix with the patient who has adenomyosis or endometriosis, there's likely persistent of the disease. And we know that the cervix does not have any function at all. Again, well, that's another conversation for another day. Does it guarantee symptoms relief? The pain might persist due to disease and what I mentioned. Remember, I talked about central sensitization. Central sensitization is the most notorious phenomena that we are going to get for patients who have endometriosis. This is where the nerves have been sensitized, that they interpret as pain even when the stimulus is not there. So that one, it doesn't matter. Even if you baptize them with all hormonal treatment, even if you give them the very best surgical option, this patient will always have pain, which is very unfortunate. Ovarian conservation is very important because that we know that the function of the ovary will still remain. The reason I mention this is because I know numerous women who have had their ovaries removed for the treatment of endometriosis, which in me, I think that is really criminal. And that should not be offered, because we know the role of the hormones that are going to be produced by the ovary, including estrogen, is very, very important in the woman's So ovarian conservation, 6-fold risk of recurrence, pain, 81-fold greater risk of reoperation with oophorectomy. But then again, the important is, please make sure that you are removing the disease. Is there an option that patient might be offered this option? Absolutely. If you're in a place where you cannot if you are a place where you cannot completely excise the disease, let's say the disease is in the lungs or whatever, then in that situation that you can possibly have a discussion with the patient that, because of this, the role of estrogen, maybe removal of the ovary should be given as an option, but that should not be the primary treatment option that should be given to patients. You again have to look at the risk of recurrence and the benefit of the influence of the hormones for these patients. Ovarian removal, again, is a long-term consecutive early menopause likely. Again, this is what we have talked about. And the risk of giving them hormonal replacement therapy, which also includes the risk of developing cancer of the breast. How many slides did I have? Okay, so surgery guides, again, this is when you're giving surgery, what is the patient fertility? Fertility is very important. And there's something we call endometriosis fertility index. So once you're, again, the fertility, endometriosis fertility index is when you go in, what do you find? What is the disease? What is the age of the patient? So there's a certain very nice protocol that we follow. And then if you're having EFI that is high, then that means good outcome, that the patient's pregnancy in 1 year is about 67%. But if you have very low EFI, then the risk of them getting natural conception is significantly low. And one of the factors that put us to decide on EFI is going to be the severity or the stage of the disease we're staging now. This is where it comes in. And then what is the patient age? What is the, things like that are going to help us decide. In terms of now after treatment, how are we going to manage them with their fertility? Is it going to be IVF? Is it going to be intrauterine insemination, whereby we are going to stimulate them? What is the quality of their fertility, the quality of the eggs? What is their fertility ability looking like? What is their desire? How soon do they want to get pregnant? Are they even married? How long do they want to delay their fertility? All this becomes very important when we are choosing between IVF and other options. Now, preventing recurrence, and this is again, as I mentioned, adolescents are a very important group because we know they have a long way to go before they can think about fertility. If they are developing endometriosis early, that means they possibly like to have this progressive disease getting worse. And recurrence prevention, if you're going to prevent them from the recurrence, then we can put in what we call a Mirena, which is a hormonal IUD, or we can start them on combined oral contraceptive for a period of up to 2 years. And this is where I have to talk to the parents and say, you don't worry, the combined oral contraceptive is possibly not likely going to affect their future fertility, but it's going to help them significantly in terms of progression, in terms of the disease. So you might need to have this discussion with them. And most patients or most of these teenagers, they're going to have less risk of having surgery in the future, and their symptoms could actually get better because you are catching them early and you're actually stopping the possible stimulation of these lesions. So that means the progression of the disease is significantly reduced. Long-term hormonal therapy reduces recurrence of deep endometriosis. Of course, we know that when pregnancy is not immediately desired. But if patient has fertility desire, their fertility should be, by all means, prioritized. What about adolescents? Again, we said first line hormonal contraceptive or progesterone. We've talked about it. Second line is going to be this GnRH, which we talked about, which I think they are not very friendly. So again, they should be given very, very cautiously. And in my practice, I don't offer this as an option. If the patient is not responding to the first line option of treatment, then surgery becomes a possible option. Surgery, complete laparoscopic excision plus postoperative hormone therapy to reduce recurrence. I still feel that this is a gold standard in terms of management of endometriosis, whether it's minimal disease, whether it's advanced disease. I think right now we are just about to publish outcomes of patients who undergo laparoscopy and then put on hormonal treatment, because you're removing the disease and then you're taking them to level 0 and then reducing the risk of recurrence. Postmenopausal and incidental finding. We know that postmenopausal disease can still remain active. So sometimes you might be told that, wait until you get to postmenopausal, your symptoms are going to go away. We know that the disease does not go with postmenopausal, especially adenomyosis. So do not wait for your postmenopausal thinking that the symptoms are going to get better. Of course, they could get, that your symptoms are going to disappear. Of course, they could really get better. But also, we also need to find what is extensive disease do you have. If you have disease that is infiltrating the intestine, if you have disease that is affecting you have pain during sexual intercourse, these symptoms are going to persist whether you get to postmenopause or not. But if it's minimal disease, you have done ultrasound scan, there's no significant disease, and the patient is close to postmenopause, maybe you can say, let's wait and see. Or these patients are responding to hormonal treatment. These are the good candidates that you can say, okay, fine, maybe postmenopausal where you're not going to need this hormonal treatment. Your symptoms are responding to hormonal treatment, then possibly you might want to see how you're going to to be like a new pelvic mass warrant oncological guidelines. So again, postmenopausal patients, these are patients who are likely to have cancer. Do we see relationship between endometriosis and cancer? Now there's evidence that is showing us there's certain cancers which are likely to occur with endometriosis. So any new mass that was not there before need to be evaluated to reduce the to do as a workup for risk of malignancy. Other medication like estrogen, again, we know those should be avoided because of higher risk of malignant transformation, because we know most cancers are hormonal driven, whether it's the cancer of the ovary, whether it's the cancer of the endometrium, whether it's the cancer of the breast. We know most of these cancers are hormonal driven, so we should be very cautious with hormonal treatment for patients who are postmenopausal, irrespective of what there is. What about incidental and asymptomatic disease? These we don't do anything about it. We counsel the patient about the findings and we tell them you don't need anything as long as you don't have symptoms. This was incidental finding. Leave it. Do not routinely excise, ablate, or medically treat if the patient has no problem. Now again, you see what it means. We are only going to treat the patient who have symptoms. If the patient has no symptoms, please leave those patients alone. Let them be. Let them be okay. Only follow them just to make sure that there's no organ that is being compromised. The ureter are not being blocked, so the kidney is not going to die. There's no obstruction and there's no surrounding organs where the diseases is being affected. And this is again where I say you're still going to need an expert to do your ultrasound scan. And this is going to be very important. Now, the things that I'm keeping repeating, ladies and gentlemen, just remember those are the very most important things in the journey of your treatment. And again, by now you can actually tell that treatment is a little bit more complex than some of my colleagues might actually put it out there. Consider ultrasound scan surveillance. Of course, as I've mentioned, advise the patient to seek care if symptoms develop. So these patients who have no symptoms, have ultrasound scan done, have ultrasound scan. If everything is not getting worse, if the kidney are functioning normally, bowel is okay, no problem. If you have no symptoms, fine. If fertility is not affected, you're not trying fertility and there's infertility, no problem. If you follow and you find that the ovaries are okay, the ovarian reserve is fine, no problem, but they still have fertility reserve, it's a variance which is going to be important for the asymptomatic patient. This is going to be among my last slide. So again, now this is the pathway of management. Now, how do you put this together? Now, this is how you put this together. If the patient has endometriosis, associated pain is a principal problem. The first thing we've said, start them with the first line combined oral contraceptives. Again, you can see there's not much pain medication here. Again, you either give them progesterone or the Mirena or the implant. NSAID or pain medication may be added at any stage. So the pain medication, they are not like the first line in terms of treatment. I hope you've noted that. So if you have been given hormonal pain medication alone, then know that there's not the appropriate medication treatment for endometriosis. And the question is, have you had ultrasound scanner? What disease are we managing? So continue treatment, reassess periodically. If the pain relieves within 3 to 6 months, if the answer is yes, patient continues with the hormonal treatment. If the answer is no, for me, I go for surgery. Some will say go to the GnRH, add back therapy. This is exactly where now you are going to put patient on medical menopause. If pregnancy is desired, no postoperative hormonal therapy reduces recurrence, then the patient will get on the fertility index, which is going to be on the next slide. Again, on the medical treatment, if the pain is still there or there's refractory of the pain, then you're going to on aromatase inhibitor and or laparoscopic excision. Again, you can see laparoscopy is when medical treatment is not helpful. Again, you're going to continue monitor the patient. If you're going to put them on hormonal or these GnRH medication where you are cutting off the hormone, it's always very important for you to monitor bone health because most of these patients are going to complain with joint pain. Then you need to do their calcium level just to make sure that you do not have reduced bone density because they have risk of getting fractures. And that will not be a good side effect or complication from the medication. Surgery may be offered earlier for deep endometriosis, endometrioma, and patient preference, refer to the center of expertise. Again, this is not, if you're not going to follow this as it is, how is the patient desire? Do they have side effects? So you might find you might not really follow this. If you put them here and their problem is actually side effect, then possibly you might offer them surgery. The patient might have fear that whether they say, for me, I don't want to take this hormonal treatment. I don't trust this hormonal treatment. I understand. When you have given them information, they can decide to have surgery as a first option. What about fertility is their main problem? Then if fertility is your the main problem, do not use ovarian suppression for fertility. So we are not going to use hormonal treatment, in other words. Assess the endometriosis fertility index, disease stage, tubal function, ovarian reserve, and male. So this is where you are evaluating and investigating them for fertility. Is there anything else that can explain the infertility, including blocked tubes? Maybe the sperms for their partner, the sperms is low. So all these tests needs to be done before we can put that in consideration. Is the surgery indicated because of pain? If the patient has pain, then surgery becomes indicated because this is going to reduce the risk of pain. So for early disease, then operative laparoscopy improves pregnancy versus diagnosis laparoscopy. See, we know that the data has shown us that once a patient has early disease, they have laparoscopy. You go in and you remove the disease. Their fertility, spontaneous, getting pregnant naturally is significantly going to increase. If the patient has endometriosis of the ovary, you remove the cyst wall, avoid routine surgery before you do IVF or what we call artificial treatment. Deep endometriosis, pain, based on pain reference, then this patient need to go to an expert center because if you have deep endometriosis, you are going to need multidisciplinary team, as we say. So you're going to calculate the endometriosis fertility index as the one I've shown you on the previous slide. Then you see if it's 9 to 10, they have about 67%. If it's 0 to 3, they have less than 10% of chances of getting pregnant. Again, that should be discussed. What is our take home? Treat the person and not to treat the disease. And I think to me, this is the very most important. And this is what I keep saying on my social media. You are not treating the disease. You are treating the patient. So don't look at endometriosis and say, I'm going to treat the endometriosis. In this endometriosis is a patient who has plans, a patient who has fertility desire, a patient who living in a community, a patient who has emotion, a patient who has people. You have to treat the patient. So you have to listen to the patient and go far beyond their disease. And not only in endometriosis, I think in every disease. And I think that what makes most of us better is by treating the person and not treating the disease. Pain and infertility are two distinct tracks. They need separate strategy. I think we have been able to demonstrate that today, and that should be very important. Ovarian suppression never treats infertility alone. That we have been able to explain. Hormonal therapy and surgery are complementary, not competing. No evidence shows either is generally superior for pain. That we have been able to demonstrate. Escalate hormonal therapy, tire, analgesic, combined oral contraceptive, progesterone, GnRH agonist, aromatase inhibitor, wherever they are needed. But you do not have to follow this escalation for all the patient. The treatment should be customized based on the patient need and the patient desire. Surgical principles. Laparoscopy, we've said, of course, over open surgery, cystectomy for endometrioma, and if it's deep endometriosis, it needs to be performed by an expert, all in a multidisciplinary team. In terms of fertility, use the endometriosis fertility index to individualize fertility counseling and the time of treatment. Endometriosis is chronic. Set expectation for recurrence, long-term, and sheer management. Patient need to understand what this means for them. They are likely to have a recurrent disease. What does that mean? So that patient is able to walk this journey. Again, is not a one-term outcome. And this is where patient come and say, oh, Dr. Njagi, I've seen, I think you are the best. Patient need to understand that I'm only here to walk this journey with them and to have them understand what this journey looks like. It is not a one-shop stop. It's good for them to understand what does it mean, their fertility journey, risk of recurrence. They need to be compliant and they need to be also respectful. Alafu, last but not least, they need to have furaha na tumaini, and that's what is called hope. And once you give them hope, they'll really understand that even when I have pain, this is what it means, but there's still better days coming. Some days are going to be difficult. Some days are going to be to be easy. Again, this becomes an easy journey for them. But it's not whereby you promise them this is cure, because up to now, as you have realized, we don't have cure for endometriosis. It does not exist. I hope you're going to get it someday. But up to now, we don't have any cure for endometriosis. And I think that is the end of my presentation. Thank you so much, everybody. And I see there are no questions. Oh, well, questions. So I know Esther had asked us to drop in questions, and I see there are 2 or 3 questions here. I will take those questions, and then I'm going to throw it back to Esther, because I know most of us need to go have dinner now. And I really want to thank you guys. I think this, I was rushing through this presentation because I was like, oh man, I'm eating on people's dinner. But I'm really impressed that the participation has remained constant. Usually that's what I check for me to say, should I rush? Should I slow down? So I have to also get feedback from my audience. And I think what has actually kept me going and not really rushing through the slides is because at no point I saw, the participation really falling below 10. So I really, really want to thank you guys for staying and consistently being very, very very patient. I really want to thank all of you for being here. I know this is time for us to be with family and dinner, but I really hope that this information was very important. So one of the questions is, can one be diagnosed with endometriosis even after childbirth? Yes, childbirth has got nothing to do with endometriosis. So Sheila, yeah, endometriosis and childbirth got nothing to do with each other. So, well, yes, you can. So maybe the assumption here is that maybe you thought or told that by getting pregnant is going to take care of endometriosis. No, endometriosis is still there. You get pregnant, no problem. Then once you deliver, it's going to just come back. So that is that. Where does Visan fall on the hormonal treatment? Actually, the hormonal treatment is progesterone, where I talked about progesterone. And I talked about a medication called Dynogest. So Dynogest is Visan. And you actually have spoken about it. So the Visan is a trade name. So we have Visan. We have another one called Endogest. So it just depends on what molecule. But all these fall under the category of hormonal treatment and not the oral combined. So there's oral combined, there's a progesterone only. So it's where it's falling under the progesterone. What is the best treatment for someone with polycystic ovarian syndrome? I think I'm not going to talk about polycystic ovarian syndrome because that, again, when you ask me the best treatment you've seen for me, has taken me almost a whole 1 hour and 30 minutes to talk about treatment of endometriosis. If I talk about polycystic ovarian disease, it's going to take me another 2 hours. So allow me grace not to talk about that, because just again, I cannot really tell you this is a treatment as you have actually seen from treatment for endometriosis. I've been using Visan Endogest, but the treatment haven't helped me in pain management. My left leg is always numb during the period pain, during urination pain, during long 3 days indoor, can't wake up due to, again, Lydia, you've seen me talking about the progression. So for you, I'd really say I'm not really sure that you need to even have this GnRH, the Luproride or Luprodex or whatever that put you in medical menopause. I'd really say you need to have a conversation with your fertility, your endometriosis specialist. Please have a good ultrasound scan done. And once you have a good ultrasound scan done, then that should be able to see what we are dealing with. And that should be able, and I'm not sure if he's still here. I'm still trying to see if he's here. There's a very good gentleman who is very good in ultrasound scan. I think he left. I was looking for him. I saw he was here. I think he's our amazing guy who does ultrasound scan. And I'm not here to market him, but I think he left. He's called Ondimu. Ondimu, I'm not sure if you're there. If you're there, please, you can raise your hand and say hello, good evening. I don't know, but it looks like you left. Okay. There's another guy called Martin Bundi. He's a guy who also do Martin. That's you, right?
Yes, that's me.
Okay. So, and again, guys, I'm not here to market anybody here. I'm just really telling you because I mean we are here to really, give you options here. Martin is actually working with me, and I think he's an amazing guy who's coming in terms of ultrasound scan. He does all my imaging, and I don't think I have really questioned. I really like about this guy because he's actually works for Kenyatta, but he's taken time off to come and learn and train, and he really spent time with me. He comes to me with operating theater. He gets to now see it in real life. One thing that most radiologists or most imaging guys are never ever going to experience, because you need to see the disease on ultrasound scan, then you need to know what it looks like in the operating theater. So this guy comes to my operating theater and he stands there for a whole day. So I know I have never told him, but I think it's also good for me to highly speak about him when he's here. And I think he's the guy who's upcoming. You will see his name one of these days. I tell you, among the guys who are going to do amazing things in imaging for endometriosis, I'm holding his hand, and I know he's going to do amazing stuff. Talking of which, the reason why I'm in Romania right now is because we are here. We are running a course on ultrasound scan for endometriosis. So this is something that is very big, and the course that I'm here for is actually being run by the European Endometriosis League. So you can really see the imaging is something that is very crucial in terms of diagnosis of endometriosis. So what am I saying in other words? Please get somebody who can be able to do good imaging. So you could be on that diagnosis, but then you have extensive disease which is not going to respond to medical treatment. So that becomes very important. And please, Martin Budi, you please tell Ondimu I had mentioned his name, but he left. So make sure that he gets that information. I'm happy to be here, Victoria. I'm happy you're here. Good to see you. Thank you for your time. It's my pleasure. What else could I be doing on an evening where there's really nothing much than being here talking about wonderful things. You mentioned Africa is underrepresented in research on endo. Where is the biggest gap? Is it diagnosis or treatment? Farida, it's in everything. Funding, interest, talking about it, resources, infrastructure. It's actually in everything. Well, look at me. I'm the guy who does endometriosis, but I'm still having problem with data. So we need to do research for sure, and we need to we need to do research. So there's a big gap. Unless there's somebody here who's interested in research, we can see how we can join hands and work together, because African women need to be represented on the global map. It really makes me sad when I'm on these international conferences. I always say there's no data from Africa. There's no data from Africa. African women are not represented, which is really embarrassing sometimes. So it's really embarrassing for me, but I hope one day we are going to be intentional about it. We are going to do work on it. So Farida, the question is, what can we do? I think we need to get together. We need to, join hands and see how we can help each other. So Njeri, if a patient is responding to hormonal treatment, once treatment ceases, the symptoms recur, does that mean they have to be on treatment for the rest of their life? Well, not really. It's not really for the rest of their life, but they will need to be on this treatment. So surgery or medical treatment. I would say medical treatment if that is working for them. But then we need to also have imaging, also find. So we are going to treat them like someone who is asymptomatic. So we are using medication to take them to a symptomatic point. What did I say about asymptomatic? You don't do anything to this patient, you just observe them. So the same thing I'll say for this patient, if they have symptoms, you've given them medication, you have taken them to asymptomatic, then let them continue with the treatment. No problem. It's all. Charles Ruvembe. My first time in this session, I am a sonographer. Very informative session. Kudos, dog. Charles, you can really see that women needs you and they need your skill. Please let me know how I can help you. You have Martin here, and I tell you, please look for Martin. Martin is an amazing guy, and he has a good heart. I can tell you for sure. So if you also want to learn this skill, and not for money, but to make a difference and to help women, we will be able to work with you. We are going to help you. And I'll tell you this for free. We still are the ones who are seeing the biggest volume of patients who have endometriosis. And then again, the only advantage that you are going to get that you're not going to get anywhere else globally is that you can also have an opportunity to come to operating theater and see what you see, so that you can really translate what you're seeing to what we want to see. And you also get to understand what it really means. When you give me a diagnosis ultrasound scan, what does that translate to me to make decision for the patient? So you also get to learn that your decision on making ultrasound scan carries a significant effect on the patient outcome. So you become a very, very important person in this treatment spectrum. So again, Charles, get in touch with Martin. So I think he's here. You can side chat him and see how we can kind of work together. But me have been having period cramps, and they have grown worse as years move. Got diagnosed with blocked tubes this year. Could it be connect? Yes. Remy, you possibly dealing with endometriosis, possibly. And again, remember what I said, I'm not sure if you're here, but especially advanced disease of endometriosis can lead to fallopian tube blockage. So for me, number one, if patient has really bad symptoms and they have tubal blockage, they have come because of fertility, and either the fallopian tubes have something we call hydrosalpinx, there was fluid in the fallopian tube, they are very likely to have endometriosis. So that means their fallopian tubes were okay. The blockage is at the end. So you have fluid that is collecting this fallopian tube, it's bulging. So if you have hydrosalpinx, you have this extensive pain, and you're having this pain, you're possibly likely to have endometriosis. You need to see one of these guys or a center that is doing good imaging for endometriosis. Unfortunately, there are not many in the country, and rule out endometriosis. Faith Jambi. All right. Where is Faith Jambi? Hi, doc. How can I book an appointment with you? Faith, God, my appointments. Okay, fine. Let me just do the number here. I'm not going to talk about it. My clinic number is there. Again, Esther. I'm going to give my number, but I'm not here to really market myself. I think this is, we have to make it very clear. That's not why I'm not here. I'm not here to give my number. And the only thing I'll ask you, Faith, is that please be patient with my clinic. My clinic is very, very booked. So if they give you a waiting time of 6 months, just please, it really gets very, very busy indeed. But I've shared my number there. Okay, where was it? There are many messages. God. Okay, I've done that. Bundi, Martin, great conversation, amazing. Martin, you're a good guy. Kind share your contact with the listener. All right, Martin, now you are the guy. You are the next guy on the block. So please help where you can help. Yes, if you can help. Doctor, please, if there's no cure, then please, what is the purpose of the surgery? So there's management and cure. This is what it really means. When you cure from a disease, the disease has completely gone. It's never coming back. So you're cured for it. So surgery is really management. So you're going to, if you do surgery, most patients are going to have less pain. So pain is going to get better. It also depends on where the level of the disease. So the thing is the reason why patients are not because they have endometriosis, is because they have the symptoms, which is going to be pain, which is going to be infertility. And that's the reason why I say it again to relate to your question, is that if patient has no symptoms, they have endometriosis, there's no need for treatment. But if they have symptoms, then you're going to treat them. So the reason why you're giving them surgery is because you want to improve their quality of life by the treatment. So that's the reason why you offer surgery. It's not you're trying to cure the disease. You're trying to give them a quality of life. So the question is, if you had disease and you have this excruciating pain, and I say surgery is going to give you 1 good year, would you take it? I think the answer is yes. For some patient, they can have 5 good years. For patient, 10 good years. For some patient, eternity until they're old. So again, as much as we are saying that there's risk of recurrence, we also need to also understand that some patients are going to have significantly improved quality of life. Have been having irregular menses, 3 months without menses. No, they come later, last 1 month with loss of clothes. I think Xiaomi, that's a totally different conversation. That is very difficult for me to tell you what it is. You need to be investigated. Why you having this irregular menses? Is it hormonal? Is it polycystic or very, PMOS? What could it be? So again, that's a very difficult question for me to answer in 1 minute. I will definitely let Ondimo know. Thank you very much. Beatrice Kandega. Kandega, I think today only great people are here. Kandega is an amazing person. She's also again from KNH. And I'm really sorry for Martin and people that I'm saying where you work. I think for me, it's really to send the message there that even in a referral hospital, they're still good people. Kandega is one of the most amazing laparoscopic theater nurse that I've worked with. She's really amazing. She makes our life easy. If you go to Kenyatta and you're having a very complex surgery, Kandega will have to know. So I'm really glad that she's here. And I think for her being here, it really represents that the work that we do in terms of these treatment option is quite extensive. And again, I was saying, this whole outcome is not about me. It's a team, and you have a great team, and this team is working alongside you. That's how you're going to end up having good outcomes. So Kandega, thank you very much for being here. Really appreciate. God bless you for the great work that you're doing for a patient in Kenyatta. Really, really, truly appreciate you for being here. Asante sana. On Saturday, hi dog, I'm a sonographer specialized in fertility. I would love to sasa mlikuja wote na nyinyi. Sasa mlikuja wote. All right, Martin, now you have a responsibility here. And I know you're going back to Kenyatta. Please, anybody who's here who is a sonographer, please get in touch with them. We are going to do a short course together. We are going to work. Martin has given his number, 07980228849. Now, Martin, just know that you are going to get a lot of phone calls coming in. And you ask me, once you become when you get on the spotlight, what it means, but I know you're good, you're going to handle it. So again, on Saturday, please get in touch with Martin. We see what we can do together. Where is Martin Booth located? Nairobi. Where can go for ultrasound scan? I think you have his number there. You're going to get in touch with him. He's going to sort you out. Very insightful session. Thank you so much. Speaking as a clinician and classic endo case, able to attend from Malawi. Oh, Ulemu, thank you for joining us from Malawi. God bless you. All right. Thank you, Doc. Nice way to see you doing what I love this with my heart. I love this with my heart. And I think this was a calling, so to speak, the least. This is my first time to be here. Please, can I get the previous lectures on the topic to listen to them? Also, is there a WhatsApp group created in case of question? Victoria, I will again refer you back to Esther. I know she records these sessions and then she's going to put them on YouTube. So again, I know she's going to share the YouTube link. So follow up on our previous conversation. We should be able to do that. That should be a problem. And I think she's already done that. Thank you so much, Doc. Nice always to see you doing what you do best. Thank you so much. Oh yeah, I think that has been answered. Perfect, perfect. I have a question, sir. So Fountain, just ask the question. If you, I think it's coming. Can a frozen pelvis be treated with surgery? Oh my God. What is frozen pelvis? Maybe I should ask you that. Frozen pelvis means that there could be possibly extensive disease of endometriosis. So if possibly you had open surgery or laparoscopy, they told you have a frozen pelvis, it means, this is what it means, the intestine are stuck to the uterus, the ovaries are stuck together, they could not separate the organ. So that means you have extensive disease, and that means you're going to need to have ultrasound scan done to see the extensive of the disease. You're possibly going to need surgery. So the answer is yes. The frozen pelvis can be treated using ultrasound, but what are we treating? What is causing the frozen pelvis? That is a question. In most cases, it's going to be endometriosis. And then it's not just because it's frozen pelvis. What is the symptom? So if there's frozen pelvis, if there's no symptoms, why should we be bothering with the frozen pelvis? No problem at all. Kindly for your clinic, as much as busy, for those who booked, we shouldn't wait for like in 2 months. We book for them not to communicate. We come from different places. We need to plan for our end or two. Sue, first of all, I'm very sorry. Truly, truly apologize. I'm very sorry. I agree. Nobody should wait for treatment, and I'm a true advocate of that. I am, unfortunately, there are not many endometriosis specialists that are doing what we do. I will tell you one thing too, and I think this got me paused a little bit. Today, my wife called me, and this is what she told me. She said, I am not happy the way you are continuing with your life. I am not happy you're staying at the clinic till midnight. I am not happy you're operating till 2 a.m. I'm not happy you're leaving at 4 a.m. to go to the clinic, to Nairobi. I am not happy you're not having time with your son. I am not happy you keep traveling the world and you're not here with us. Right now, I'm doing this, whatever, I'm in Romania. So, as we are speaking right now, I have bookings that are up to March next year, and I really did not want to talk about this. I'm only one. I would really wish I could get solutions. And if you have a solution here, please, you can post it on the post. You can post it below here, and I'm going to implement it. I'm human, and I get tired. I get exhausted, and I get frustrated as well. But for the love of women, I cannot walk away. I don't know what vacation means. I can tell you I've not had vacation for the last 3 years. And even when you see me outside the country, I'm not on vacation. Possibly the first vacation I had was a few months ago, or it's a few weeks ago, when I took my mom and my kids. And this is because my mom was sick. And I had to cancel clinic for me to go. And if you actually follow me on social media, you saw me complaining because patients were actually insulting us because I had to cancel the clinic because I had missed the flight. I would really, and I'll talk to my clinic, they can communicate better, but we are really trying our very best. We receive more than 100 phone calls in a day, and you wouldn't imagine what that means. There's one thing I really hope for, that there can be many people who can come out that Sue, you don't have to wait for only Dr. Njagi, and they can be, let's say, 100 endometriosis center. I given you statistics. There are about 1.5 million women who possibly suffering from endometriosis. And I know there are 1,000 who would want, not Njagi, but the services that Njagi offers. I really hope there are many Njagis. I think that's the only way I can respond to your question. And I know you need to plan for your end too. And I know you also have plans. I truly. And we're going to do better. So one thing I'm going to ask you, Sue, tonight, get on your knees and honestly and genuinely talk to the Lord and say, Lord, we are in a problem. And I really ask that you give us a solution other than Njagi. And I really hope God will hear that prayer. Because I would also want time to say there are many options. And now I can take a break and I can rest. I really, really hope that. Finally, last but not least, I show you. And I really was not planning to do this, but I think that got me a little bit emotional. I don't know if you can see my screen here. God. There. You can see how many messages that are waiting to be responded to. 242 messages. That is my WhatsApp. And that's not my clinic number. That's the clinic number I've given is 0799, which is on social media. So on mine alone, I have 242 messages that I need to respond. Again, Sue, what I can say, I'm very sorry that you have to do that. And we'll still keep doing our very best. Yes. Next question. Always here for learning purposes. I have learned a lot and it has impacted me and the patients better. I'm also a sonographer and I have come across several cases with endo. Would you recommend the referral process? Again, Mercy, as you've heard my message to Sue, in terms of referral, I think that's answered the question. I think as long as you give them the right diagnosis, to me, that's the most important thing. Fountain Nawoma, can frozen pelvis be treated with surgery? I think that I have done. Hi, doc. My friend has been experiencing blood stain, yet not in her menses. Okay, well, again, that is also very difficult for me to really answer what is really going on. She might need possibly to have an imaging ultrasound scan done. That should be done to really figure out what. I cannot really tell why she's bleeding. There could be many causes of bleeding. Is it she has fibroid? Is it she has adenomyosis? Is it that she has inflammation of the cervix? Is it that she has endometrial hyperplasia? Is it that I don't know? So she would need to have a conversation. It's very difficult for me just to answer with just that one line. Does someone with endometriosis always wear a pant liner? Oh God, that's a very difficult question, but the answer is no. Victoria Deola, let me use this opportunity to say you made me love Kenya and the song. I am Victoria from Nigeria, living in UK, and I can sing the song from A to Z. Thank you for all you do. God bless you. Victoria, please do me a favor. Please do me a favor. And I know we are not in a rush. Esther is going to allow, if you can unmute yourself and sing for me the song, I'll be so happy to hear it, the Nigerian version. Could you do that for me, please? Victoria? Is Victoria still there?
Yes,
Please,
I'm here.
please sing for me, Kristo Anayamoyote.
Just a minute, please.
I have all the time.
Oh dear. Oh my God. Cristo wane emayote imashamo yoagu nifulizo ya baraka inashasha guegu unifuse nikupende nikuweke kote moyo wangu ukwaje furaha na tumaini. Should I continue or let me just stop there?
Thank you. Thank you, Victoria. Thank you.
Thank you so very much,
Thank
Doctor.
you.
God bless you and your family. The song is really touching, and I pray God will use you more and more. And please always have your rest. Thank you very much. Thank you very much.
Thank you. Thank you. Thank you
Thank
so
you.
much. Thank you so much, Victoria. I really appreciate it. God bless you. God bless you. That song was not my choice. It was chosen by a patient. Oh, wow. Thank you, Victoria. Really, God bless you. Victoria, I will, let me see where this, I don't know why I can respond to you. Oh, God. Where's Victoria? Victoria. Victoria, I will respond to you. God. Oh, where is it? I want to send you my number, Victoria, my personal number. Please, if you can just I don't know how to do this. Oh God. Esther, please send Victoria my personal number. So
What?
Victoria, please have my personal
I
number,
will,
and I'd really
What?
love to talk to you.
I
It just,
will.
yeah, it's really, please, Victoria, allow me to please send me a WhatsApp message sometime, and I'd really want to call you. I cannot really believe you're from Nigeria and you're really, really singing the
I'm
song. God
from
bless you. God
Nigeria.
bless you.
Thank you very much. Thank you very much. I do not take it for granted. Oh, God, I'm really blessed. Thank you very much. Thank you very much. God bless you. God
Amen.
bless you. God
Amen.
bless you. God
God
bless
bless you.
you. I
Thank
saw
you.
a Kenya person 2 days ago at work. We were working together. She's a lady. Her name is Grace, I guess. Yeah. And she told me she was from Kenya. I left what I was doing and I gave her a big hug. And I told her, "Do you know because of you, there's a doctor in Kenya." I told her and she was like, "Wow." I sang the song and she was really happy. I'm really blessed. I'm really blessed. Thank you so very much.
Yeah, man.
Thank you very much.
I'm now
God bless.
I'm now your new friend now.
Yes,
Now that you
yes,
know the song.
yes, yes,
Power of music.
yes.
Amazing.
Thank you very much. Thank you. Thank
Thank
you.
you so
Thank
much. So please send me a WhatsApp message.
you.
I will definitely get back to you.
All right. Thank you very much. God bless you. Thank
All
you.
right. All right. Um, so, Anne, hello, doctor. I went through surgery in March this year, and after being diagnosed with umbilical endometriosis of late, I occasionally feel slight pain on the left in my tummy. Occasionally, is it worrying? No, I will not really see it worrying. If the umbilical endometriosis was removed, then that's fine. Minimal pain, that should not be a problem. We just need to observe and follow up you with the symptom. Then we see how that will go. Perfect. So yeah, I would say observe that, and if the pain is getting worse, then we can always see. Pami, how do I go about the hydrosampic? What is the solution? I think, as I mentioned earlier, this was a question that was asked. If it's hydrosampic, so that means it's fallopian tube blocked and it has fluid. Again, the question is there pain? Is there endometriosis? What exactly are we dealing with here? So that should be the question that we need to ask ourselves. What are we managing? So Pami, I think it's a more conversation than that. How bad is hydrosamping? So are you trying to get pregnant? Then you need to have that conversation. How, whether the tubes can unblocked, which is a little bit difficult, or this is going to be a recommendation for IVF. That should be the conversation you need to have, because hydrosampics, if it's true, that means that there's this blockage of the fallopian tube. Doc, is it a good idea to be on norethindrone long term, and is Implanon a better option severe endometriosis management? I think norethindrone is a tablet that you swallow, which is a progesterone. Implanon is again a hormonal treatment. Again, remember, I did not really talk about hormonal independently. They all maybe work the same thing. So if one, there's no one which is superior than the other, as we saw from my presentation. So again, Abby, allow me to actually say that there's really no one which is superior. So I cannot really say use this or don't use this. Again, it depends what is really working for you. Dog, you're doing good work, but your wife is very right. Salfenda, thank you very much. And I really say, I really give a lot of credit to my wife. She's not here, and she does not even know I'm speaking about her. But she's the one who has allowed me to do this. I'm away from home for the most of the time. She's the one who's taking care of the kids. She runs a very busy schedule as well, but she's actually given me permission to do this and to take care of the home. So she knows how passionate I am for women and how I'm passionate about this. And I really give her a lot of credit. So please, you guys pray for her that, she can still remain strong. But today she actually told me she's not happy. So I need to behave myself. So noted. Thank you. You're very welcome. Very welcome. Lean. Oh, God bless you, Doc. You are a champ. Well, thank you. May the name of the Lord be glorified. He's the one who has enabled me to do this. So, and my wife giving me permission. All right. More grace and strength to you. You're a great gift. God bless you. You and Esther for organizing you. Thank you very much, Dr. Susan. God bless you. God bless you too. Well said presentation, Doc. Esther Namayan, thank you very much. God bless you. Hi, Doc. Great presentation. Kindly, kind of clinician specialized in this other than RH. Well, unfortunately, the way our regulation see does not really give us a lot of freedom to do this for clinicians. This is the unfortunate thing about it, because then it's going to be very limited. So you need to be, at least now what I know, the regulation, you need to be a gynecologist for you to do the entire spectrum of management, including laparoscopy, which is again confined into very small field, which is gynecologist. But still, there's a lot that we can do in terms of, let's say, diagnosis and having like a clinic expert. So, for example, I say Martin and the guys who are here, they actually know gynecologists. They are sonographers, and they're doing amazing work in terms of really helping in terms of working together. So we can also still try to find where can we have our level. So it can be a clinic of expert. In my clinic, sometimes I work with clinicians, and they are really able to, in terms of history taking and initial assessment and things like that, they can do the first initial hormonal treatment. Then when it gets to a point of, let's say, referral, then they can refer for, let's say, expertise treatment. So again, that becomes a possible option. So don't really think that it's limited, Clara, because you're not, you cannot do medicine or gynecology. There's still a role that, we can also play together. If pelvic scans came back clean, but the periods pain very unbearable, you give hormonal treatment for dysmenorrhea, it comes slightly bearable, but upon the coming of the treatment, pain back little worse. So first of all, who did the ultrasound scan? The thing is that even when we do ultrasound scan and there's nothing, it doesn't mean there's no endometriosis. Oh my God, it's 2 hours. I need to finish. So you guys stop asking questions so that I can finish. I don't want to leave anyone without their question answered. And I don't want to rush through them. So if you take medication, the pain disappears. Continue taking medication. Because remember what I said, when you're taking this hormonal medication, it's only quiets the disease. The moment you get off, pain comes back. So again, things can actually get a bit distressing. Allow me to respond to one message. I'm okay. Almost done. And God, I had another meeting now. Oh Lord. Yeah. Sorry guys, I just need to make sure that they have not reached out for the next meeting. Okay, fine. Not yet. Okay, fine. So the next few questions, I'm going to take the next 5 questions now because I think that's the one remaining. If we pursue GnRH antagonists, what is your specific bridge plan for the adback therapy to protect bone density and management of vasomotor? Masharia, I think that is a very complex. So we give adback therapy. So this is going to be definitely, you need to give estrogen as a bad adback therapy. There are different protocols out there. Vasomotor, and vasomotor, basically what he's asking is going to include the thing about my head is going blank. The sweats and the hot flashes and everything. So, we can give some nerve medication that really helps. But again, since this is as a result of the hormonal treatment, we're looking at the benefit versus the counter options of treatments for us to give adback therapy. So I give, for example, for me, I never do for more than 6 months because literature shows there's not going to be more evidence of giving more than 6 months. So there's a lot of evidence that we are really finding now. Instead of really saying this is what you give. However, I mean, this is a conversation we can have. I really say use your oral combined contraceptive, use the long therapy that you're not taking break in between. So like there's no 7 days that you're taking off treatment. Love you, Victoria. People loved you. They loved you. All right, Dr. Joy. I did my undergraduate degree in Romania to say goodnight. Noapte bună. Noapte bună. Now who will I say goodnight to? Okay, fine. Thank you so much, Dr. Joy. At least I have 2 words that I didn't know. I'm in Romania. Bucharest. Let's use this opportunity to say you made me laugh. Okay, that's Victoria. Thank you very much. Judy, sorry, join the conversation. How can we get you, Doc? I was sent to see you by Dr. Yama, but I have not been able to get you. Again, I'll do my clinic number there. Or else talk to Esther. Esther, you can give Judy specifically my number. I can reach out to her. If she was actually sent to me by Dr. Amal, that's a colleague referral. So we really would see how we can be of help. Yes, thank you so much. I pray God Almighty continue to bless you and all that concerns you. Thank you very much. I really wish to stop here. Thank you so much, guys. God bless you. It was really a pleasure for me being here. Thank you so much for coming. Thank you so much for staying. I really hope that this information that we have shared today is to not only help you, but you can, when Jesus had his 12 disciples, and he said, please go out and teach the world, because he could not reach out to everybody else, your friends. So what I really hope that this series and the information that we are spending time here sharing it with you, we hope that you can spend to many more, that we are going to have more people getting information, because when we get information, these are going to get easier. People are going to be able to make decisions for their life and for their health. And we are going to reduce the suffering years for women who suffer from endometriosis. Up to that point, Esther, thank you so much for the opportunity. You can really tell vacations are working for me. You can see I have energy today compared to the last 2 sessions. So make sure that when you're getting me, at least I'm not on my regular working day. So when I get these breaks, I get so much energetic. Honestly, guys, the last time I canceled because I was completely beat. I could really not do this, and I really felt sad calling Esther, canceling it. But at least, Esther, today I have been able to prove to you that when I have at least 5 hours of not working, we can be able to really have a great session. So hopefully we have one more session, and hopefully we'll get to meet all of you again. Victoria, I'll be looking forward to talking to you once you send me a message. Thank you so much, everybody. Have a good night, and God bless you. Be a blessing. Be a blessing. And that is my parting shots. Back to you, Esther, and you guys will allow me to log out, and we'll see you next time. God bless everybody.
Thank you. Thank you. Thank you, Doc. Thank you. We'll see you next Wednesday, same time, same place, same link, as we handle fertility and impact. Thank you. God bless you and good night.